start the webinar. I will start in 3, 2, 1, and we're live.
Okay, so good evening and good afternoon, good morning, everyone. So dear all FARO members, we are very pleased that your participation in our 34th FARO webinar. So today we have a topic about introduction to stereotactic body radiation therapy for liver cancer in Mongolia. And thank you all for joining us today. So before we begin our main session, I would like to invite Dr. Imjai Chitapanaruk, FARO, President of FARO, for greeting remarks. Dr. Imjai, please.
Thank you. Good day, everyone, and a very warm welcome to this webinar on SBRT for liver cancer in Mongolia. This event is presented by the Mongolia Society of Radiation Oncology, and we are honored to be joined by the expert panelists representing FARO member countries, the Philippines, Japan, and Korea. As we know that liver cancer remains a major global health challenge, particularly in Asia, where the burden is among the highest, especially in Mongolia, the incidence and mortality rates of liver cancer are particularly alarming. So this making this discussion today not only timely but critical. So sharing experiences and insight across border can accelerate the adoption of such advanced techniques, as for example, SBRT, and can improve patient outcomes in our regions. We look forward to a rich and engaging discussion that we hope shape the future of liver cancer in Mongolia and beyond. So thank you for joining us today, everyone. You're muted.
Thank you, Dr. Imjai. I'm sorry for your kind greeting remarks. So I'm Bilegsaikhan Batsuuri. I will be the moderator of this webinar. And so first, let's move on to the main session. Today's topic is Introduction to Stereotactic Body Radiation Therapy for Liver Cancer in Mongolia. I would like to introduce our presenter, Dr. Uranchimeg Tsegmed. Dr. Uranchimeg Tsegmed is the president of Mongolian Society of Radiation Oncology. She is also a council member of FARO and a member of a leadership development program. And Dr. Uranchimeg has 20 years of working experience, and her special interest area is SBRT for liver and lung cancers, gynecological cancer, head and neck cancer, brachytherapy, and radiation safety and radiation emergency medicine. So, Dr. Orna, if you are ready, please.
Thank you, Dr. Bilegsaikhan, for your very kind introduction. Can you see my slides?
Yes, we can see.
It is okay. Thank you. So it is our honor to host today webinar for MOSTRO, and it is our great honor to have our FARO president and officers, panelists, and participants join with today webinar. Thank you all for your coming and participating in this webinar. Today I am going to share our experience with SBRT for liver cancer, and especially sharing our experience for introduction of SBRT for liver and lung cancer in Mongolia. According to the Global Can, so you can see here the liver and stomach, lung, and esophageal, also cervical cancer common in Mongolia. So also, unfortunately, also we are leading the total cancer mortality in the world among the 185 countries. Oh, sorry. And in the right side of the slides, you can also see the world average rate of the HCC is about 8.5 per 100 population, but standard rate is 96 per the 100 population in Mongolia. This is, you can see, the more than 10 times higher than world average incident rate. In 2024, 8,100, about 70 mortality morbidity were diagnosed, and also 4,755 mortality rate was rated, and about 64% of patients were diagnosed the late stage, and 60 of the newly diagnosed patients died within a year. As well as the WHO Gulbakan predicted that 2040, the cancer incidence will increase by 96% in Mongolia. This slide presents the treatment options for the liver cancer in Mongolia in 2023. That year, incident rate was 2,000, about 400. Then 35 patients underwent surgery, and 36 patients received liver transplantation, and almost 1,000 patients received interventional radiology procedures, mainly TASE and RFA, and 750 patients received palliative care. For the radiation therapy, in that year, we haven't yet introduced it. Then 2024, we introduced the first radiation therapy using SPRT and 3D CT using hyperfractionation patient with HCC. So now I would like to show some evidences based on the clinic trials. As you can see in here, for SPRT for liver cancer, some studies shows outcomes. Then all of the type of the studies show the local rates were higher than 80%. Then you can see, especially the depend on the size, the control rate were the more higher, and we can also we can so this is was published in Red Journal. Then that is summarize the outcomes of SPRT using 70 studies from the database. The full 5 years local control was 82%, and grade 3 and more toxicity was 4%. in that study. Then in a meta-analysis of study rated as a high quality and concluded the SBRT can achieve similar local control and overall survival as RFA. Then this results, especially the last retrospective data, showed positive result of the SBRT compared RFA, especially for the large tumor. The outcome was much higher than in SBRT the side. That meta-analysis show us the comparison TASE versus TASE and with the SBRT and higher rate of the partial and complete response were observed, especially in arm of TASE plus SBRT and but some complication like including gastric and duodenal ulcer and also evaluation of the ALT and the bilirubin were observed due to the radiation-related complication. And these studies, 22 ASTRO clinical practical guideline, the radiation therapy is strongly recommended as a potential first-line single option for the patient with HCC, especially whom is not candidate for curative standard option. For also the TASE is being considered, and also the latest edition of NCC guideline in 2023. So radiation therapy is one of the local treatment options for patients for whom resection is not indicated. So now I little bit talk about the background of SBRT for HCC. So as we know, nowadays machine and treatment planning system advantagement allows us to deliver much higher dose with more accurate and more safe for the organ intrinsic. So we could increase the doses per fractions doses to the tumor. Then but the SBRT criteria generally same as the other option of the treatment for liver cancer, such as surgery and RFA, TASE, etc. However, the SBRT has an advantage compared with other treatment options. So especially in suitable for the surgery or RFA or after the TASE, the incomplete response, we can refer the SBRT, and also during the period waiting liver transplantation, we can give the SBRT for the breast treatment. And some palliative cases, especially patient with portal vein thrombosis, we can deliver hypofractionated radiation therapy. Then this slide shows the preferable solutions of the SPRT for liver, especially based on the size. If we deliver more safely the SPRT, so size and number of the lesions are important. Then in our hospital, we are following, we are using and adapting the Japanese e-cook studies outcome, especially the protocols from the Hiroshima University. Then regarding to size, we prepare to the less than 5 centimeter lesion and less than 3 number of the lesions. Then due to the tumor location, you can see here, especially the lesions located just below the diaphragm or surface of the liver near vasculature, or the tumor is invisibility by US ultrasonography. In that case, we can refer the SPRT. And due to the patient condition, if patient have the comorbidity and also with the cirrhosis or with the obesity, diabetes, etc., then SPRT could be one of the good option. And also the after RFA, TASE, and resection, the patient has the reliefs, then we can do the SPRT. Then this is some of the examples of the referral cases, and you can see especially these cases just below the diaphragm, and these cases in just liver surfaces, and this case is near to the vasculature. So, and radiation biology of SPRT is now still studying, and however we know, as we know, the direct effect of the SPRT, like the direct cell death and vascular damage, and also SPRT is immunocytokinase has immunocytokinase mechanisms. So these advantages we can these kind of advantages allow us to introduce SPRT for the liver cancer. So I would like to share our experience how to implement this project. So we first started our implementation through the IAA technical project MON 6021. Then that is our purpose is the improvement of the quality of radiation therapy for cancers through the introducing lineup-based SPRT in Mongolia. Then in this slide shows that just brief information, general information about the projects, and the estimated duration with from 2020 to 2024, and that is a project like a schedule. Then from in the beginning of the project, actually during the COVID pandemic, then we had challenges. However, we could solve our project by purchasing the required necessary procurements, including like upjets and some of the dosimetry devices, and also the COM-beam CT, upgrading our current LINAC by the COM-beam CT, etc. Then after pandemic, our team, multidisciplinary team, were trained at the Hiroshima University. Then 3 radiation oncologists, 2 radiation therapists, 1 medical physicist trained from 2 months to 6 months. Then we also developed protocols for SBRT lung and liver cancer. And the last year, exactly 1 year ago, we invited experts from Hiroshima University and Professor Nagata and his team to our institute. And during this the visit, we did on-job training and conferences, and most importantly, we could started our first cases with the experts. Then this is some of the essential procurement. Then most significant the procurement was the with our government support, we procured and installed TrueBeam, which is most modern version of the variant TrueBeam. Then mainly we use up-chest devices for the respiratory motion. Then you can see from these slides all of the multidisciplinary team members, like Dr. Bilge was trained, and me, and also Mr. Ondrich, our medical physicist, were trained 6 months, and other two technicians, Miss Altantoya and Ganzul, were trained. And this photo shows our first cases, treatment planning, and after we treated the first cases, we took this photo. And let me move to the next part, is that introducing more deeply clinical protocol, which is using our institute. Then just before introducing our first SBRT, we approved our protocol. This one is we know the SBRT sequence, the treatment sequences. Then that table shows all clinical results of the patients. So far, we have treated 8 patients, and 5 of them with liver cancer or liver metastasis. You can see here is 4 primary liver cancer. 1 is liver metastasis. Then other 3 cases were the lung metastasis cases. Then for the liver cancer cases, Child-2 score in 5, all of them with the A, and TESE, 2 of them received TESE, and response so far we just become 1 year. Then so far the complete response were 5, and then you can see the partial response 1 and 2 of them were still under the follow-up. Then we have not the time to just evaluate the responses. That one is one of the cases with the primary liver cancer. Then patient is female and 56 years old, and patient received partial hepatectomy in 2023. Then after that, 1 year later, patient detected recurrent cancer in liver. Then we treated the patient with 40 gray in 4 fractions. And you can see that planning. In this case, we treated with the Hiroshima University experts, especially with the Dr. Imano and Dr. Kawahara, Okumura, Professor Nagata. Then that is after 5 months responses, you can see. And now the patient will be also come to for the next follow-up. Then for the introduction of the SBRT, we have some challenges. So I would like to share some challenges with you. So one of the common challenge was regarding to the selection criteria of the SBRT. As we know that the selection criteria is almost same as all other options, like for the surgery and RFA TASE. So SBR patient with liver cancer, they first go to the surgeons. Then surgeons mainly they prepare to do the surgery. So the SBRT's new technology, surgeons are reluctant to prepare the patient to us. And second, the big challenge is regarding to the institution, cost of the treatment. Then that treatment is still not yet included our national insurance system. In Mongolia, if the patient with cancer, the government pay all of the treatment, then that meaning is patient receive treatment free. Then but for the institute like hospital, we receive it budget based on our implementation and receive the budget from health insurance based on our implementation of the treatment. So in that case, actually, we cannot receive budget. So, but our institute is cover all of the treatment cost. And one of the another challenge we are facing is the maintenance of the machine is really expensive. So in the first year, we didn't have the maintenance contract. So in the case of in part of the machine broken, so it took a few months. And getting the service, it takes the month, some time. So it could also it can induce to reduce the number of the SBRT case. But we still finding solutions. So regarding to the referral of the patient, so with this advancement, we are now equipped to provide world-class treatments to our patients. So we give them more information to our doctors, like surgeons and interventional radiologists, and also as well as for the patient. And also our doctors involved with all kind of multidisciplinary the tumor boards and find the referral patients. And the second solution, we already introduced our new technology to the National Health Insurance agency. So we hope from the next year that will be included in national health insurance. And regarding to maintenance service, even it is expensive, but from this year we made a contract with private company, and we made the full maintenance contract. In that case, any part of the machine broken, the company will solve within the certain period, which is mentioned in the contract. So then I would like to conclude my talk. Then SBRT should be considered in a multimodality approach, especially for the inoperable HCC cases or after relapse of the lesions after surgery or TASE RFA. So, but the multidisciplinary team in making decision is most important. And regarding to delivering more safety in achieving more good result, we should consider about also the criteria like size and number of the nodules. So as we know, that depend on the size. If the size is small, we can see the more good results. And also, SBRT is well recommended for the so we should show our results to the patients and to our colleagues like surgeons, hepatologists. So the number of the patients to repair us will be increased. Then outcome of SBRT is almost same, and then sometimes it is better than RFA or other option of the treatments. This is just conclusion and achievement of IAVA among 2061 projects. Then, as I mentioned, during this project, we procured very expensive the equipments and Linux, and we trained our teams and developed protocol, and most importantly, we introduced the first cases of SBRT, and to implement new technology in the medical field, it takes a lot of the time and efforts from many people, especially including the based on like multidisciplinary and partnership, international partnership and projects, and also the team member efforts. Especially in this time, we really expressed our great thanks to the Hiroshima University for their long period partnership to introduce this partnership and support to introduce this project and new technology. And that's all for me. Thank you very much for your attention. And just from our panelists, we would like to discuss especially on these the points like regarding to the patient selection criteria and size of the tumor and number of the lesions, and also the doses for the one fractions, etc. Thank you.
Thank you very much, Dr. Uranchimeg, for your informative and insightful presentation. So before we move on to the discussion session, I would like to introduce our panelists. So we have three brilliant panelists who has specialized especially in the SBRT field. So first, Dr. Mi-Sook Kim. She works as a chief of department in Korean Institute of Radiobiological and Medical Sciences. Since 2008, she has published over 120 clinical and biological papers, and her special interest area is gastrointestinal cancers, including liver SBRT. And our second panelist is Dr. Nobuki Imano. He works as an assistant professor in Department of Radiation Oncology, Graduate School of Biomedical Health Sciences in Hiroshima University, Japan. He has many impressive research works, and he has a special interest in pediatric and lung cancer, brain tumor, and palliative radiotherapy and gynecological cancers. So our final panelist is Dr. Ryan Anthony Agas. He works as an assistant professor of University of Santo Tomas Hospital, Philippines, and he is also the head of the hepatobiliary stereotactic radiotherapy program. His special interest area is gastrointestinal cancer and adult bone and soft tissue sarcoma and SBRT. So in the discussion session, I would like to ask each panelist in about 5 minutes to share their experiences and any comments and about the topic. So, Dr. Mi-Sook Kim, would you please share us with your experience, and if you have any comments about the topic, please.
Okay, thank you for nice introduction for me. And my name is Mi-Sook Kim, and working for KIRAMS, Seoul in Korea. It's the request of a moderator, and based on my own clinical experience, I would like to share some insight on SBRT of HCC. At our institution, we perform SBRT for HCC primarily using CyberKnife system. SBRT session with the CyberKnife typically take more than 40 minutes, and some cases require the insertion of a fiduciary marker. Therefore, elderly patients or those who have difficulty maintaining a stable position for prolonged time, we recommended lineup-based SBRT instead of CyberKnife. In most patients, abdominal compression is applied to minimize tumor motion. We use a homemade abdominal compression device, which has been working reliably in our clinical practice. We acquire 40 CT scans to account for respiratory motion, and the tumor is controlled on each respiratory pace, and some of those controls is defined as the internal target volume, ITV. A planning target volume, PTV, is then created by adding a 2 to 4 millimeter margin to the ITV. It is true that SBRT becomes technically challenging when the tumor diameter exceeds 10 cm or when there are more than 4 regions. However, I do not consider it impossible. My general approach to selecting SBRT versus alternative techniques is based on whether radiation-sensitive organs are involved with the PTV. If a critical organ such as stomach, colon, small bowel, or bile duct is definitely included within PTV, I prefer to use hypofractionated radiotherapy instead of SBRT. I would like to briefly comment on radiation dose. As long as the tumor is adequately covered by prescription dose, I believe that delivering 45 to 50 gray using 3 to 5 fraction can achieve tumor control rates approaching 90%. Currently, our standard SBRT protocol for HCC is 10 gray by 5 fractions in our institute. Basically, in patients to have a child-proof CP score over 5, our dose constraint based on Timmermans table is at least 700 cc of uninvolved liver normal liver to receive less than 21 gray. If the total volume is initially less than 700 cc, or if the patient has a CP score or 7 or higher, we still can consider SBRT but reduce the total dose to 40 gray according to those constraints, or consider hypofractionated IMRT or none, no treatment. Finally, I would like to comment the treatment schedule. We have typically 2 to 3 day intervals between fraction, resulting in total treatment duration of approximately 2 weeks for 5 fractions. For example, the treatment is delivered over 2 weeks on Monday, Wednesday, Friday of the first week, followed by Monday and Thursday of the second week. This protocol was originally introduced maybe 10 years ago in the phase 2 study to reduce gastrointestinal toxicity in our institute. Interestingly, our preclinical studies have shown that increasing the interfraction interval, like the 5 days in the mouse, may also enhance tumor response through increasing cytotoxic immunity. For more detailed information, I will refer you our publication in the Red Journal. Thank you very much for your attention.
Thank you, Dr. Kim, for your very impressive comments. So, Dr. Imano, if you're ready, please.
Yeah. Yes. As Dr. Olga showed, we were involved in the introduction of SBLT in Mongolia. So it was great honor to take part in the country's first SBLT case. Thank you very much, Dr. Alna, and all of Mongolian National Cancer Center doctors. It was also a great experience for us. And I'm really happy to hear that the first patient is doing well. So thank you, Dr. Alna, for sharing the follow-up situation. Thank you very much. And according to the patient selection criteria, actually, we share our protocol to Dr. Alna, so almost same, but I also repeat the patient selection criteria. In terms of patient selection, the tumor size, usually I think around 3 centimeters is the ideal, but we expand the patient selection criteria up to usually 5 centimeters in Japan. In Japan, if the tumor is bigger than 5 centimeters, we consider using proton therapy. So usually the good candidate is usually 3 centimeters and maximum 5 centimeters in Japan. And about child Pew score, child B7 or lower is a good situation. Usually we don't perform SBLT for child B8 or higher. We usually consider these criteria. And the number of tumor, so synchronous multiple lesion, usually we adapt up to 3 lesions. But first we treat two tumors, and 6 months or 1 year after, then we can repeat 2 or 3. So each time 3 is our protocol. And about achievement, actually, so SBLT is already excellent treatment, and it has good local control. And I think with the adoption of VMAT, SBLT quality become much better. So usually the tumor is located close to intestine. It was difficult, but these days we can modify the dose map and reduce the intestinal dose and increase tumor dose. We can expand the patient indication with VMAT. That's our achievement these days. And also challenges in Japan. In Japan, our government approved many systemic therapy, including immunotherapy, tyrosine kinase inhibitor. Many these new drugs are used also in liver cancer. Then we have to consider the toxicity to normal organ. Usually, liver cancer, we don't use TKI or ICI, but this is, we have to care this systemic therapy, the timing or those to normal organ. And also, with this systemic therapy, HCC cancer patients live longer than before. So that's why we have to consider much more about late toxicity than before. So our challenge is next challenge is a combination of systemic therapy and SBLT. Yeah, that's my opinion. Thank you very much.
Thank you very much, Dr. Imano, for your impressive comments. So, Dr. Ryan, could you please share your experiences about the topic?
Hi, can you hear me?
Yeah.
Yeah. Thank you. Congratulations to Mongolia as well. So I think in the Philippines we're a bit on the same boat as Mongolia, because I think most of the centers are just recently starting their SBRT program. For example, in our hospital, the University of Santo Tomas Hospital, we've just started our program in 2021. And I think that started after I came back from fellowship training in Peter MacCallum Cancer Center in Melbourne. So since then, we've started doing SBRT for multiple sites, including liver. And I'm focusing mostly on the liver patients. So we've treated a little bit more than Mongolia. We've treated, I think, around 15 patients since that time. So definitely, we're still in our early days. So, and I understand the challenges that Mongolia is encountering with their development of the program. So, but I think bulk of my experience still would be during fellowship, because Peter Mac already has a very mature SBRT program now. So I think one of the specific challenges in the Philippines locally is, except for one center that's putting up a CyberKnife machine, I think there's no center that has a SBRT, an SBRT specific LINAC. So we share, our SBRT patients share the LINAC with all of our other rad-onc patients. So spacing of the patients, and most centers only have 1 to 2 linear accelerators. So treating a lot of SBRT patients is a bit challenging. So in terms of the selection criteria, I agree with both Dr. Kim and Dr. Imano in a way. So I agree with Dr. Imano that the outcomes are best treating smaller lesions, less than 5 or less than 6 centimeters, and fewer lesions. But I also agree with Dr. Kim that larger lesions is not impossible to treat now. To be honest, the largest lesion HCC that I've treated when I was a fellow was up to 18 centimeters. It was a lesion that's on the right side. I was asking the consultant, was she sure we were doing this? No, but we treated that lesion because it was all on the right. It was on the right side, and liver function was very good. Was still very good. So the patient tolerated treatment with no toxicities. At least during the time I was there, and during the time that I was able to follow up that patient, there was no toxicity. So if you look at the inclusion criteria of the RTOG trial, actually they treated a lot of really large lesions there, including many patients with MVIs, macrovascular invasions. So I think there even larger than 10 centimeters, there could still be some patients who would benefit with SBRT as long as their liver function is still very good. Yeah, I think that's all that I can add to what Dr. Imano and Dr. Kim has discussed. Thank you.
Thank you, Dr. Ryan, for sharing us your experience. So Do we have a question from the audience? So
I wanted one question to Dr. Imano. Frankly, I want to know why the criteria of the SBRT just limited to size below 5 share. What's the reason?
Mhm. One of the thank you very much. The biggest reason is insurance. Government approve the HCC smaller than 5 centimeter. That's the biggest reason. But another reason, so we have proton therapy, or as Dr. Lyon said, according to clinical trials, the good candidate is smaller size, and we have another option. That's the reason. And I was really surprised, 18 centimeter tumor. That so I want to ask opposite. So I want to ask Dr. Kim and Dr. Lyon, if you have to try SPLT to huge tumor, like 10 centimeter, 18 centimeter, even if the liver function is very good, but I think the liver dose constraint cannot be achieved. Is it how about the dose constraint for liver?
Actually, I also treated maybe 15 centimeter diameter tumor using the RINA. The dose was 50 gray in 4 fractions, 10 gray by 4 fractions.
The B20 or
Yes,
these.
yeah, so the liver, surely the child proof 5, so the actual liver function is no problem. There's some problem is just GI trouble like that. Sometimes lung the pneumonia like that.
So my question, my question is, at that time you accept so the limit, so those constraint is not achieved, but you accept the those constraint.
Because the huge liver mass remained the normal liver volume is very small size, actually below 700 milliliter maybe. So just at that time, just at that place, maybe you cannot meet the constraint.
Maybe I think the important point is best supportive care versus SPLT. The SPLT is better. If if you don't perform SPLT, then best supportive care, then maybe we can try. But if you have another option, then we have to consider another option. That's my opinion. I agree. Yeah, if no other choice, then we sometimes have to try these cases. I think that's the point.
So just to add to that, so for primary, for HCCs, we never go below 5 fractions to be a little bit more gentle on the liver. And if the lesion is really large, we drop the dose. We look at the mean dose, we follow the constraints of the RTOG trial. So, so when we meet the highest dose that we can give, meeting those constraints, the mean dose that's recommended in the trial, that's what we give. So sometimes you can, we've given 30 gray in 5, so pretty modest dose, 30 or 35 gray in 5, pretty modest. So I agree, I think that could be considered as a radical palliative treatment and not really curative, really an ablative dose anymore. But even with just those doses, I've seen local control that's pretty good. I've followed up around 2 years, still with good local control with just 30 gray and 5. Yeah.
So by increasing the dose in the center area, you can increase the dose.
Yeah.
And then the peripheral area, you can reduce like 30 gray in 5 fraction. Then you can achieve liver function, a better liver function and toxicity, lower toxicity. Yeah, thank you very much.
Yeah. Now for metastasis, it's a little bit different.
Yeah.
My constraints are a lot. My target dose is a lot higher, so the selection criteria is a lot more stringent.
Yeah,
so
but
especially for example for colorectal mets, I like to go very high. Yeah,
higher, and then liver function is better than HCC cases, so that's the reason. Yeah.
In Mongolia, as I presented, the most of the cases are diagnosed very late stage. So our colleagues from the surgical department and interventional radiology department, actually, they asked us, so why your criteria is such very, tough? And same as like us. And if you can, actually, they really want to, send the patients, like if the size is more than 5, we can, if we can treat, they want to, send us. But for in my opinion, actually, in the beginning period of the introducing SBRT, it had better to follow more safe, like have to say, follow the safe way that is like as a ECOG, JCOG studies of the SBRT for liver and lung cancer of the Japanese study group shows already good results. Depend on the size, that we can just follow this kind of criteria. Then in later on, then maybe we can adjust in Mongolian cases. Maybe you shared your cases like Dr. Kim and Dr. Rain. So maybe if the background of the liver function is good, or a little bit bigger than 5 cm, then maybe step by step function is good for introduction or implementation period of the new technology. This is my opinion, and I really appreciate your sharing your experience. Okay, so there is one of the question.
So thank you, everyone. So I understand that one point that our panelists agreed that size doesn't matter, right?
No, not doesn't matter.
That's just
Size
issues,
does
right?
matter, but still, yeah, sometimes we can try.
Okay, so in the chat box, there are I'm sorry. So there are no questions in the chat box. So this is the closing.
Dr. Bilge, I saw that Dr. Bimba is raising hand.
Oh, so I'm sorry. Dr. Bimba, please, do you have a question?
Thank you very much for the presenter and panelists. And I have one question from this Dr. Kim. My name is Batsuuri. I'm the radiation oncologist in NCC, and I did the training course on SBRT liver cancer in KIRAMS. And just I am interested in the SBRT treatment time duration because that when I doing the treatment in a training course in KIRAMS, they did this SBRT for 2 weeks. In my institution, just 1 week. And Dr. Kim, how long did you use this intervaled SBRT? And did you do this clinical study on the efficacy and the safety of this intervaled SBRT?
As I said, the treatment schedule is very important according to reducing the complication, especially GI complication, and also it affect the patient performance. So I reported the interval period during treatment in clinically 10 years, around 10 years, 10 years ago, published, the data is published very, very, very good journals. Interestingly, the interval of the fraction is interestingly the reduced GI complication. So also in this last year, I reported the time interval, the interval between the fractionation can reduce the complication. Interestingly, the interval increased the tumor response. Maybe the reason is the increase the cytotoxic immunity. So we just approved through the preclinical research, but now for 10 years, I'm using the protocol to put the interval of 2 or 3 days interval between the fractionation in HCC or the liver or lung metastasis. So I would like to recommend it's just put the 2 or 3 day interval between the fractionation is not so difficult to patients. So I just recommend to the treatment protocol. Just refer my paper to understand the mechanism. So
Okay, thank
it's
you
very
very much.
important things.
Okay, thank you.
So thank you, Dr. Bemba and Dr. Kim. So we have a raised hand from Dr. Siti Afrora, and please, Dr. Siti. Dr. Siti, are you there? Okay, so thank you very much, everyone. So this is the closing, and I would like to express our deepest thankful to all FARO members who has joined us today, and to our panelists who has panelists, the experts of the SBRT, and for their very impressive comments, and also thank for Dr. Mayang and Indonesian team who has organized this webinar so well. And so this is it. Thank you all very much, and good night. Thank you very much.
Thank you.
Thank you.
Thank you
Thank
very
you.
much.
And
Bye.
Myanmar, bye.
Bye-bye.
Thank you.
On Hag, bye.
Bye, Dr.
Nice to
Uran.
meet you.
Thank you
Yeah.
very
Thank you.
Thank you. Yeah, I know it's closed now, but only my one word of caution to Dr. Tsegmed is what you're doing is perfectly in the right way. Go slow and have a good experience, and keeping the 3 lesions and as a maximum, and your training is good. And that is the way when once you get experienced in that, then you can even increase the dose and also the number of lesions you can do that. Good job, and God bless you. Thank you.
Okay.
Thank you very much.
Thank
Thank
you
you.
very
Thank you.
much.
Comments.
Thank you very
Bye-bye.
much.
Thank
Bye-bye.
you.
Bye.